The most common clinical error in chronic pain management is treating the tissue when the problem is the amplifier. I'm Dr. Padda. Let me explain what that means, because it explains why your imaging doesn't match your pain. Think of your nervous system as having a volume control on incoming signals. In central sensitization, and this is mainstream pain neuroscience, not a fringe idea, that volume control gets turned up and stays up. The spinal cord and brain amplify signals that would previously have registered as minor or gone unnoticed entirely. The consequence is that severe pain frequently reflects a hyperactive central nervous system rather than ongoing mechanical tissue destruction. This is why a person with a frightening MRI can be comfortable and a person with a clean MRI can be in agony, and both are telling the truth. The scan images the hardware. The pain is generated by the processing. So when we keep operating on the tissue while the amplifier stays cranked to maximum, we get exactly what you'd predict: a technically successful procedure and an unchanged patient. Pills don't fix metabolic debt. Pharmacology is genuinely useful. I prescribe. But a chronic pain condition rooted in metabolic dysfunction or lifestyle deficit cannot be resolved chemically because the chemistry is downstream of the cause. Medication manages symptoms. It does not address the terrain. If your pain is being sustained by systemic inflammation from a diet high in refined carbohydrate and industrial seed oil, by 5 hours of fragmented sleep, and by chronic unregulated stress, then no molecule I prescribe is treating your condition. It's muffling the alarm while the fire continues. That's sometimes the correct thing to do temporarily. It is never the plan. So how do you turn the amplifier down? Not by avoiding everything. This is the trap most pain patients fall into, and it's completely understandable. Movement hurts, so you stop moving. But total avoidance is evidence. Every time you don't do something because it might hurt, you confirm your brain's assessment that the movement is dangerous. Avoidance reinforces the threat model. The correct strategy is intelligent biomechanical adaptation. Modify the movement so you can perform it safely, then perform it repeatedly. Each successful movement is a data point. Your brain is running continuous Bayesian updating on threat, whether you're conscious of it or not. And it updates on what you actually do, not on what you tell yourself. Update the threat model, accumulate the repetitions, adapt the biomechanics. That's the sequence. Here's the comparison I use with patients. The assembly line clinic smashes the warning light, bills the visit, and books you for next month. The light goes out, everyone documents a successful encounter. Comprehensive management lifts the hood, identifies the root mechanics, and repairs the underlying system. One manages perception, the other restores function. Both can be billed. Only one changes your life. Two related ideas, and they're the ones patients find most surprising. First, chronic pain frequently persists as a learned habitual loop, a central nervous system pattern the brain has simply forgotten how to switch off. No ongoing tissue damage is required. The loop runs on its own momentum, and because it's learned, neuroplasticity means it can be unlearned. Second, and this follows directly, the language you use about your body is not neutral commentary. Describing yourself as fragile or failing strengthens the very neural pathways generating your pain signals. You are rehearsing the threat. My back is destroyed. I'm falling apart. I can't do anything. Each repetition is a rep for the pain. Compare, my system is adapting. I'm building tolerance. My brain is updating. I'm not asking you to lie to yourself, and I want to be clear about that because toxic positivity is its own problem. Those second statements are more accurate, not less. They describe what is actually happening in a nervous system undergoing treatment. Now, the hardest thing I have to tell patients, and I say it before we schedule anything, no procedure survives a hostile environment. The most advanced interventional technique available, performed perfectly in the right patient at the right level, will ultimately fail if that patient returns to a lifestyle that actively feeds systemic inflammation. Four things carry the veto: sleep deprivation, an ultra-processed diet, chronic psychological stress, sedentary behavior. Any one of them can outlast my best work. Together, they will. This isn't about blame. It's about sequencing. If we address the terrain first, or at minimum alongside, the procedure has something to hold on to. Which brings us to how I think about the whole thing. Medical intervention resets the hardware, procedures, structural correction, a period of neurological quiet. That is my job, and it ends there. The software is yours. Movement patterns, sleep architecture, nutrition, stress regulation. Permanent recovery happens only when the patient owns and runs the lifestyle software daily. I can reset your hardware as many times as your insurance permits. It will not make you well. What makes you well is what you run on it afterward, and that is not a limitation of medicine. That is the actual mechanism of recovery, and it puts the controlling variable in your hands. You are not a passenger in this. If you want a pain practice that will treat your terrain and not just your signal, that's what we do. Padda Institute Center for Interventional Pain Management. 4477 Woodson Road, Suite 100, St. Louis, Missouri, 63134, next to Lambert International Airport. Also at 12174 Natural Bridge Road, Bridgeton. Call 314-481-5000 or text 314-886-5902. Educational content only, not medical advice. Speak with your own physician before changing treatment.